Welcome to the Architecture of Healing, the podcast where healthcare strategy, design, and operations come together to shape environments that support care delivery and healing. I'm your host, Chase Miller, and today we're diving into one of the most fascinating intersections in healthcare, the point where architecture meets neuroscience, aging, and human potential. My guest, Dr. Addie Abushousheh, is an architect, environmental gerontologist, and researcher whose work challenges us to think differently about how our environments can enable healing, not just accommodate it. From traumatic brain injury units to FGI guidelines, she's uncovering how evidence-based design can empower both patients and staff, reshape outcomes, and prepare us for the future of care. We'll talk about the competence press model, dementia-friendly design, and the business case for evidence-based environments, and how we can stop discriminating against our future selves through the way we design. So whether you're an architect, clinician, or healthcare leader, this conversation will make you see every hallway, waiting room, and care space just a little differently. Let's get into it. Awesome. Welcome, Addie. It's so great to talk with you today. I'm so excited to have you joining the podcast with us. Looking forward to this conversation.
Thank you, Chase.
We've known each other for several years, gotten to know each other through the Center for Health Design, I think starting with some of the interactive diagrams, and we've presented together and done a lot of different work in the past. I'd love for you to just share a little bit about your history, how you got into healthcare design, gerontology, and the evolution of your career trajectory.
Yeah, that has been the road less traveled for sure. When I was really young, I absolutely knew that I wanted to be an architect. And then I had like this intersection of the trajectory in high school by a couple of instructors who introduced me to different aspects of STEM programs. They didn't call it then back there, but that's essentially what it was. And I started doing genetic engineering and applied physics and things like this, and started taking a deeper dive into the way that physiologically and cognitively we function as a species and interact with our environment. Now, this didn't necessarily diminish my enthusiasm for architecture, but it certainly pivoted it a bit. So when I went into my degree, rather than kind of buy into the whole, if you build it, they will come, or that we can shape people's behavior and that they aren't agents, I was not buying into that. And so I picked up a second degree in organizational development and leadership studies to go along, because it was really, I saw architecture fitting at the intersection of organizational kinds of programming and then operational approaches. And it could either be a barrier or it could be a facilitator. And where I was especially interested in this, almost like experimentally so, was where cognition was concerned for people who had some type of vulnerability or injury. So immediately after finishing those degrees, I went to work at a traumatic brain injury unit to just learn staffing routines and language and work with individuals to try to understand how the environment could work intuitively. You pull a lever, push a button, and turn a knob. The feature tells you what to do with it. But whenever we're really clever and we try to do things that are fun or that are fads, we end up outsmarting ourselves, and we definitely outsmart a lot of the people that we're trying to help in healthcare environments. Fast forward, I had been working as an architect within the healthcare arena and was expressing some frustration to one of my mentors, Vic Rainier, who is just a renowned environmental gerontologist, about the fact that I was not getting to work with the clients and the staff that I was working primarily with, the folks in the C-suite. And he says, if you're really serious about this, you need to go get your PhD. I thought, oh, yeah, that sounds hard. He says, oh, yeah, by the way, there's only two that kind of fit where you would like to focus. One's in Germany and one's in Milwaukee. So I bought a really good coat and moved to Milwaukee to study under Jerry Weissman and Yuri Cohen, who were doing absolutely, phenomenal work. Mentored both by Powell Lawton, the granddaddy of environmental gerontology. So I kind of feel like I'm the third generation coming through that is looking at the way that, the environment, organizations, human potential, and research will intersect.
Yeah, it's almost like taking the old phrase, form follows function, and like dissecting function.
Yeah,
And how does a space function, and why is it functioning in that way, and how does that impact the people in it, and vice versa.
absolutely. And, there's this phrase that I discovered along the path that I think it was Robert Kane who said it, that if you value something, you evaluate it. So that dissection of the function, but also the form, and understanding that interrelationship and anything else that might be influencing that. Like for me, I acknowledge my geekiness, but for me, that's really exciting. That's where some magic happens, because that's where we can put tools that were previously in our tool belt into the hands of designers and healthcare providers to really just to leverage the therapeutic potential of a building and finishes and layouts. And it's not just a pharma intervention.
And you mentioned working in a traumatic brain injury clinic or department. I didn't realize that. How did that begin to shape the way you view environments, not only from kind of the patient perspective of those types of patients, but just being in a clinical setting and experiencing space in that way?
So that was definitely a life altering kind of period of time. I worked with people aged 16 to 86, all who had undergone very different kinds of traumatic brain injury. The majority of them were motorcycle accidents. So anybody who's listening to this, helmets can definitely save lives, but when your life is saved, there can also be consequences for hitting things with your head at high speed, no matter what kind of helmet you're wearing. But that wasn't the only type. And so one of the things that I was especially interested in was not only the patient population and the capabilities, but what I didn't think about going into that was the effect that the different therapies would have on the way that I view the environment. It changed my perspective of life safety. So the way that I look at NFPA now in comparison with the way that I did, whenever we're thinking about self-preservation and capitalizing upon and enabling people to be self-sufficient, you know, certainly in life-threatening situations, but just in daily interactions. If we're designing based upon the occupational and physical therapists' analysis of populations with the 6-minute walk test, with range of motion, grasping capability, visual deficits or capabilities. These are all things that from an environmental perspective, if we really shape the environment almost as a prosthetic, it enables them in a way that they do not have the same reliance upon staff. So staffing capabilities change. And it also enables them in a way to maintain a functioning or enhance a functioning. So there isn't the excess disability that we see in terms of the trajectory with a lot of the care environments that people currently reside in, either from a rehabilitative, acute, or long-term care perspective. And this could include residential households as well. So that, I think, it gave me a different way of being in an environment and hearing people and watching things play out, as well as acquiring and screening information from a research perspective. I now have what some of my colleagues lovingly refer to as the sniff test. The here's what it says it does, here's what the outcomes were, and was there statistical significance? But like, does it smell like it's gonna work in practice? Knowing the things I know. And that's probably another area where, Chase, there's been a little bit of a divergence in terms of my trajectory. When I went into the PhD program and started a PhD in architecture, I took, I think, one architecture course. Everything else was in nursing and business, communications, social work. And there was a smattering of others that I was really shaping an entire way of kind of dissecting and viewing the environment that very few people had done before. And it was really because of the organizational development in combination with that traumatic brain injury experience.
Wow. It really is so interesting to think of space as an enabler and how it's something that allows us to live life, right? No matter what our level of ability is. Just thinking about my weekend, it was 100 degrees, and having space that was cool and air conditioned allowed me to be human and not a puddle on the ground.
Yeah. Similarly, if we think about just modifying or manipulating the environment and having that adaptability, that's another thing that I think is really critical in all of this, because in different kinds of care environments, we're not caring for one single individual. It's this collection and array of capabilities where the environment really needs to be adaptable to personal preference, capability, and need.
So I have an interesting question. When you think about the environment as an enabler, have you ever come across instances where those enabling portions of the environment become disabling to a different group or population type?
That's a really interesting question. I hadn't necessarily thought about it like that before. However, what I will say is there's this really wonderful 2-axis chart that was developed by Powell Lawton in combination with Namaho. And it's just referred to kind of generically as the competency press model, where on one axis you have personal capability from low at the bottom to high capability at the top. And then on the horizontal axis, you have the complexity of the environment. So really low complexity, simple demand at the far left, high complexity at the far right. And really there's this zone of adaptation in the middle that occurs that's like your sweet spot for people. So if we put this into the context of your question, and we have a really very capable person who's in a very simple environment, we can actually disable them because we aren't forcing them into their zone of adaptation and highest performance. I equate this, by example, to skiing. So if you have a black diamond skier, you're not going to put them on bunny hill. It's going to not be challenging enough. They're going to lose interest quickly. It's going to be something that is beneath their capability. However, you are not going to take a beginner and put them on a black diamond. They absolutely need that bunny hill. Most of us are somewhere in the middle, right? You don't want the bunny hill, but you are terrified, rightfully so, of the black diamond. So that's where, if we were to play this scenario out in healthcare, if you have an extremely capable population, let's take, for instance, because I don't want to frame the entire conversation in terms of just deficit. Let's say you have people who are in the NFL or NBA. people from a sports perspective who are receiving therapies, who are pushing themselves, who use and leverage and need different environments. You put them into a traditional rehabilitative kind of healthcare arena, and it's not going to be helpful for them.
We've talked a little bit about the 4 M's of age-friendly health systems. Can you talk about how that work and how your work has kind of derived from that, maybe connecting that to the metaphor of the ski slopes, right? Of the different ranges of ability.
So right now there is an age-friendly health systems initiative that CMS, the Centers for Medicare and Medicaid Services, is rolling out within acute care arenas. And they are basing this on what they're referring to as the 4 M's. And that is mentation, when we think about cognition, medication, mobility, and what matters most. There's this fifth elusive M that really ought to be integrated into this, and that's multi-complexity whenever we think about aging. And this is something that Diana Anderson, a colleague, talks about pretty extensively. What's interesting about these 4 M's is that each one of these can be viewed as both an input and an outcome from a healthcare perspective in relation to the built environment. However, at present, the Age-Friendly Health Systems Initiative does not have an environmental component or requirement. The way that it's being handled is hospitals who are participating and who have been involved in the pilot have basically determined for themselves what their approach is going to be to improve outcomes related to these 4 M's. And they have articulated it. So they're collecting data based upon what their inputs are, and likewise what their outputs are before the intervention and after the intervention. And then they're reporting those. Interestingly, within the confines of skilled nursing, memory care, and other settings, especially environmental gerontology research, evidence-based design, we've been collecting this data for years related to the environment's impact on these outcomes. So in hospital environments, when we're talking about exceedingly vulnerable populations, we actually have disproportionate negative outcomes as a result of both practices that we employ as well as the environments that we're doing it within, because we're not playing to those capabilities. So when I think about just colloquially calling it design for dementia, designed to accommodate individuals who have lower coping thresholds and reduced capabilities when it comes to sensory processing, if we're enabling everyone on that level, design for dementia actually just turns into really good design within a healthcare environment. Because if people aren't impaired walking into a hospital by virtue of procedures that we're doing or things that they're experiencing, news that they're receiving even, we can certainly impair them on the way out.
Yeah, it's almost like, to your point of the care itself and then the environment, they're being designed in a silo, kind of in isolation from one another. So the care and the models of care are being developed by clinical experts, physicians, providers, as a way to get people healthy. And the environments are being created, by designers and architects, in many cases without that input. And so they're not talking to each other. And as a result, you have places where the process conflicts with the environment and vice versa, creating those clash points that aren't resulting in positive outcomes.
Well, and Chase, this is where I think our working relationship and certainly friendship has blossomed, because you and I both, I think, view people who are coming to the table with regard to conversations or who have knowledge as subject matter experts. And we can't necessarily replicate the kind of expertise that, say, a person with early or stage dementia has. Similarly, you and I have no experience being a registered nurse on the floor, nor have I ever been a chaplain. I've never been a transportation specialist. I haven't worked in facilities. Like, we have to have all of these people at the table to understand this machine that is healthcare. It's commonly referred to, at least in the literature, as a complex adaptive system because of its complexity, but also because of that need to have continual adaptation. You move one thing and it changes the context for everything else.
Thinking about your background in business, how can we move the needle for healthcare organizations to develop a business case to have greater forward thinking in terms of the environment? So we've developed this model of care that we believe is going to get patients healthier faster. But we don't have a business case to spend $10 million to integrate the space to match the model of care. How do we help as an industry come together to create that business case to follow the research that proves the environment is going to reduce or improve outcomes?
So in terms of the business background that I have, it's in nonprofit management. And so I kind of couple evidence-based design with mission-driven kinds of goals. And if we can, right from the get-go in our planning process, come together again as a collective of subject matter experts, this is where I think the gold is, because we can start to identify both those quantifiable outcomes that are unmistakable. We're collecting data on them as hospital systems, and we know where deficits are. If we have staff retention issues, if we have fall issues, if we've got medication mismanagement issues, certainly we have never events, things like that are so easy to spot. And those can be guiding lights for what we do from an environmental perspective. And this is where I go both into the literature as well as start to do inquiries with staff, because populations and contexts tend to be pretty specific. Some things are generalizable to other places, but in a lot of situations, even in urban, suburban, and rural areas, you have kind of a cultural identity of people where that helps to also both shape outcomes as well as the processes. So start to do diagnostics, pick apart that function and that form to identify what we can leverage from a built environment perspective that is going to impact positively the outcomes that we're desiring, as well as identify during the process some other outcomes that could take priority. Here's the business portion of that. And this gets back to, if you value it, you evaluate it. And the more you can put things in a quantitative kind of measure, the better. In our case, right now for this conversation, the more that you can do a cost evaluation. So what is the cost of a fall? What is the cost of that turnover per position? What is the cost of that never event? That's something that you have to look at the item as well as the frequency and any associated repercussions. Are those interconnected? Do we have higher turnover because we have higher never events? Those are mutually reinforcing. What can we do to leverage the built environment? That's where we get into cost estimation on your first cost of whatever that environmental intervention is, as well as ongoing costs and incremental either cost savings or revenue generation. And what's the point at which we break even and turn that into revenue? This is not a new model. This is what, our financial analysts do all the time with regard to a lot of processes, personnel, things like this, equipment. It's just we tend to be a little bit newer to it from an environmental perspective, being able to identify specifically what the cost of an environmental design is versus a piece of equipment. It can be more difficult. I think that the challenge is if you've got that going in your planning process, it makes it into the schematic and then the construction drawing documents. This is where, again, subject matter expertise. Don't overlook your contractors and your project managers, because during the value engineering phase, that can easily be cut. Something that looks extraneous, that looks impractical, that looks just foreign to someone that they've not integrated into a project. Surely we can find a cheaper way to do this. And I think it builds the case in a construction document set for having an evidence-based design sheet.
Oh, yeah. Okay. I'd never really thought about that. Because, there's really big things, right? So $1 million ideas that are going to impact the environment. But, I love the work that we did specifically on the aging waiting room.
Yeah.
Right? There's really small things that are super easy to do that have huge impacts, as simple as the color of the flooring, the texture of the flooring, the color of the throw pillows, right? The color of the furniture. Adding a clock, making this feel more residential, even though it's not. Very simple, that don't add a lot of cost, that have extreme impact on the way a patient experiences the space and reducing their level of anxiety and stress when they're in a high stress environment.
Yeah, I couldn't agree more. And in fact, so the dementia-friendly waiting room interactive design diagram, and Dongia funded that. It was done in partnership with your firm. And yeah, you and I definitely had a kind of a fun dynamic and learning curve on that one, because that was newer to you. And it was me transitioning the application of what we had been able to learn from more household kind of long-term care environments to an acute care setting. And you're right, like the simplicity of some of those moves is absolutely invaluable, but doesn't cost a lot of money. If we're thinking about like floor to wall transitions or furniture sitting within a space, having enough contrast for someone who has a vision deficit to be able to see it. Or like we had a furniture grouping, removing one of the pieces of furniture or two, depending upon what your patient population is and how many mobility devices are likely to be used in that space. So then individuals who are using those aren't tucked over here in the corner. They can be a part of the group as the group is configured in a waiting space. And that's something actually, Chase, that we don't think enough about in acute care environments at this point, because our aging population is expanding. We've got more and more different kinds of mobility devices that are being used, and people who are coming to appointments are not coming by themselves. So for our occupancy estimates are a little bit off at this point in terms of space and the numbers that we're estimating, where we should be accommodating more people.
And the whole COVID thing threw waiting rooms all into chaos, right? Of how do we actually wait? Let's reevaluate what waiting looks like. How many people really are going to be here or need to be here or should be here? But going back to this idea of the dementia-friendly waiting room, one thing that you've said a number of times to me in the past is, we're designing for our future selves. Like, we need to care about this because we're going to be there one day. And I think it's this like mentality of denial. Like, no, like I'm not going to be there. Like, I just remember one Christmas, our family gave my grandmother a walker. She about threw that thing through the window.
Oh gosh.
She was so angry. She's like, no, I don't need that. That's not me, right? Like, I'm in denial. I'm not going to be there. I'm not going to need to experience space in that way. I'm going to be fully mobile my entire life. No, we may need some different things within the space that we live, work, play, receive care in that will enable us to function at a higher degree of ability than we may have on our own.
Totally. There's an advocacy element here. And it's your grandmother's mentality, I think, is absolutely reflective of the bulk of people's reaction to receiving that kind of a gift that has, a outward message that they feel is being delivered. And if we look at this from that advocacy lens of nothing about us without us, it really does flip the script on us. And I think the most important word in there is us. We other so many people, we, them, but it's us. Each one of us is capable of stepping incorrectly off of the curb and breaking our ankle, of having something happen. You're working, and this is going to go back to the traumatic brain injury unit. If you have an aneurysm or a stroke or an unfortunate event with a binge night of drinking or any number of things, even anorexia, you can end up in a position where you don't have to be 85 and 90 years old to benefit from strategies that are sensitive to and supportive for individuals who are differently abled. And I love where our kind of neuro research is headed at this point. We talk about neurotypical and that there is no neurotypical. We all have neurodivergence in some way. And if we can start to steer into that skid, I think we're going to be so much further ahead. It needs to be about us, the collective. And we need to make decisions together and really do more digging into what it means. A lot of times I think we're afraid of our own future and we're not inclined to do the digging because we don't want to know, quite frankly. But I think that that's pretty arrogant in a lot of ways. And and this gets back to the saying that you love that I say, if we aren't actively enabling our future selves, we're discriminating against ourselves in advance.
Yeah. Yes, I love it. It's so true though. I mean, we are all patients in some way, shape, or form. And we must think about the space that we want to be cared for in, the processes that we want to be cared for by, that will improve our chances to get through whatever we end up needing treatment for. Going back to the discrepancy between the big things and the small things, right? We talked about there are these small things that we can do that are
Right.
very simple, and maybe the bigger things. How has your work with the FGI Facilities Guidelines Institute been able to promote and push forward some of those bigger things where many states see or utilize FGI in some version as code?
I think that that's a good point, that in the absence of cut and dry business case, this is where we do have standards and codes and, to a degree, even best practices. So I have been one of the co-chairs for the residential document, referring just generally as the residential document, but it's the residential health care and support facilities document. And this has undergone changes, dramatic changes, since 2014, and it's released every 4 years because we separated actually from the hospital and outpatient setting and took much more of a deep dive into what does it mean for those long stay, long-term kind of healthcare settings in a variety of capacities. And a lot of that is based on evidence-based design. And we recruit subject matter experts of all types in order to capitalize upon their knowledge and access to information. And then we also do outward bound searches for informations and take deep dives that we didn't really think about doing before. I'm going to give you a case in point. In this last cycle, one of the things that was mentioned to me, oh my goodness, it would have been nearly 15 years ago, that just continued to kind of roll over in my mind, was done by a representative of the American Bar Association at one of the surplus safety symposiums that I was attending. And this was a very small kind of think tank where we were looking at the way that we excessively disadvantage people within the built environment and actually create negative outcomes. And here I was talking with this representative and just asked the question of, what is it that keeps you up at night? And the response that I got was really interesting. It was the number of people that are aging into an age for that multi-complexity, again, I'm going to throw that word out there, in a penitentiary environment, who are being decarcerated into public healthcare settings and the kinds of negative outcomes that are occurring there. And I think about our behavioral and mental health kind of work. So with this next upcoming 2026 edition, we have an entire chapter dedicated to mental and behavioral health. We also revised the section in the common elements that applies to individuals who have any kind of sensory processing challenges, because that had been referred to as the kitchen junk drawer. It was if you had, a population that had dementia, a population that had neurodiversity or neurocognitive kinds of processes that were being affected continuously, behavioral health, and not all of those are created equal. You actually have two kind of distinct considerations for populations. One is there the potential that this population can either pose a risk of harm to themselves or others? And then on the flip side, you have another population that simply experiences overwhelm by environments that exceed their coping capabilities. So now we have two distinct sections within the common elements portion as a result of this, simple conversation. But the people that we were able to interact with and solicit information from are absolutely incredible. And this challenge exists and will, I predict, get exponentially worse because of the number of people aging into older and more complex kinds of situations coming into acute outpatient and long-term settings.
And I think it's not that those things necessarily can't be shown through a business case. It's that there are so many variables that feed into the outcomes related to those items. And so creating a financial model based on implementing those is just such a complex equation. And with the research, we can prove X, Y, and Z benefits patient outcomes, benefits staff and providers. However, taking that with all of the different components that build into that model, it becomes a little bit difficult to pinpoint. It's not the straight line of a patient fall costs this much money and we can, reduce it by X% by adding this rail. It's less clean and dry, right?
Yeah. Yeah. And I think what ultimately my goal is thinking about every environment as an opportunity to advance health. I gave the example of individuals who are incarcerated. If we start thinking about penitentiaries as places to advance health, it shifts the way that we think as designers in our capabilities what it is we're trying to accomplish with the selection of materials, with the configuration of space, with the relationship of rooms to one another, even the orientation of the building. And I don't think we can overlook also just how important workforce is in this. It's not just help for the patient population. We really have to be advancing the health and capabilities and performance of individuals who are providing those services across the board. I'm going to give one example here that was surprising to me, but if you really think about it, it shouldn't have been. In the case of one of the penitentiaries that we involved in the conversation, it was the first to do a memory care ward for individuals. And so rather than decarcerate some of their population into public settings, they had them stay there in a very special designed ward. Interestingly, that took its pointers from the FGI residential guidelines, and the caregiver population were also inmates that had received and gone through CNA training. And they studied not only the outcomes of the patients who were receiving the care, but the outcomes for the individuals who had been trained, who were then decarcerated after they had served their sentence. And the recidivism for these individuals was 60% less than their counterparts. So, I mean, maybe that's not generalizable to the general population, but that's a huge outcome. We typically don't have outcomes that are that dramatic.
Yeah, that's unreal.
But if we think about enabling and training and investing in our staff and what turnover costs, we could probably realize an increased percentage from a retention perspective pretty easily too.
Yeah. Thinking about healthcare as a whole, zooming out 500,000 foot view, if you could take one piece, part, component of the healthcare system, be it process, operations, space, and redesign it, unlimited resources, what would you fix? What would you change?
Oh, Chase, this is going to sound so bad, but I had this question actually that was posed to me when I was working with the Hulda B. and Maurice L. Rothschild Foundation in Chicago, because there was money to support intervention. And I had been to hundreds of healthcare settings around the United States and done analyses. And what I was seeing more so than anything else was the fact that when we had these either renovations, additions, new construction, you had healthcare systems or providers that somehow expected for their operations to change when they moved into the new building or occupied their renovated space. There wasn't the attention that was given, the reciprocal attention that was given to mundane things like redrafting policies, procedures, job descriptions, hiring practices, evaluation strategies to go with the building. This is where that organizational and environmental fit happens, where building is either an enabler or it's a barrier. And accordingly, architects either get the blame or the credit. And if the organization doesn't go through a similar renovation, addition, or new construction, then that's where the deficit happens. And I think that there needs to be internal teams that are HR-led, that are the partner with the environmental design side to look at the way the two mesh together.
I couldn't agree more. Lightning round. You ready for it?
Sure.
All right. So what is one of your favorite healing spaces?
There's this camp in New York that was built based on a philosophy anthroposophy. And everybody who listens to this is going to have to look it up. I presented on it because I was the only one who could pronounce anthroposophy. And it's a different kind of a construction technique and treatment of space that captures light and acoustics as a part of the healing environment in a different way. And it kind of cradles a person.
Wow. I have not heard of that. I'm definitely going to need to look that up and practice pronouncing it. What inspires you outside of work?
Oh my goodness. The thing that inspires me the most is really getting into spaces that I can watch people interact. And in fact, I can just have conversations and ask them about their experiences, why something works for them or how something doesn't work for them. And that gives me that one-to-one interaction that replicates that traumatic brain injury experience where I'm working with and kind of on behalf of.
What is a book that has changed the way you think?
Dale Carnegie's How to Win Friends and Influence People. And this, I remember from high school, is something, oh my goodness gracious, you're holding it.
I'm literally reading this book right now. I love it.
This is one of the things that, as I think about the value of every individual and being humble enough and curious enough and compassionate enough to discover it and honor it. That's something that I think was pretty life-changing.
Yeah. It's so good. It's such a great book. That's too funny. And last question. Finish this sentence. The future of healthcare is blank.
Oh my gosh. The future of healthcare is everywhere. I think, again, if we can look at the design of our cities, our civil construction, our integration of human capital, our potential with resources, our treatment of the planet, like healthcare is everywhere.
That's so true. And it's just becoming even, more pervasive, every day, especially with AI. It's wild. Well, Addie, this conversation has been amazing. Thank you so much. I thoroughly enjoy every time I get to talk with you and just unpack everything that we're doing and all the cool things that the industry is moving forward with. So thank you again for joining me on the podcast today.
My pleasure. Thank you.
And for everyone listening, I will link to Addie in the show notes, add some content down there, and provide a few resources that we talked about, including the wonderful book, How to Win Friends and Influence People. Thanks for joining us on The Architecture of Healing. I hope today's conversation brought you fresh insight and inspiration. If you found this episode valuable, make sure to subscribe, download, and give us a review. Want to learn more? Keep the conversation going and head on over to thearchitectureofhealing.com. We've got more great conversations on the way, but until then, keep shaping the future of care through thoughtful strategy, smart operations, and purposeful design.